Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
All right, thanks so much, Brian. My name is Marie Dorsey, and I've been an inpatient hospital pharmacist, currently working for Peace Health in Eugene, Oregon. I've been a pharmacist for 13 years, and 6 of those which I spent as an HIV consultant pharmacist for the HIV Alliance, which is our nonprofit here in Eugene. I'm on the board of directors now, so I'm not working with them directly anymore, but I'm able to work with them just giving advice on the board, and I can also work at Peace Health, working in the emergency department and also other inpatient endeavors. All right, I have no conflicts of interest or relationships to disclose. All right, so a little bit of an overview. As you know, we're discussing nPEP today, and we're going to go over a very brief version of the guidelines. We're not going to be focusing so much on the guidelines and what is clinically done for patients, rather putting those guidelines into practice in the real world, which is unfortunately a little bit more difficult, and helping patients to access this nPEP is not as streamlined as we would hope it to be. Last year, I've done some research on nPEP processes in different institutions, and my comments here apply to many different facilities, not just my own. I will share with you the different barriers to nPEP that I have found obtaining and payment for PEP medication, as well as the possible solutions. Lastly, I hope to provide for you some resources for quick information. Let's first do just a quick review of the DHHS guidelines. It might be the most brief discussion you have ever heard, so you can check out Dr. Harrington's wonderful review that he did May 2016, right after the nPEP guidelines were updated. And the goal is to start nPEP as soon as possible after a high-risk exposure, and ideally within 24 hours, because we want to prevent HIV from getting into the lymph nodes and then into the blood, which usually happens 24 hours after exposure. The benefit of nPEP decreases as time goes on, and 72 hours is the cutoff window for giving it, as stated by the guidelines. These cutoffs are mostly based from studies including 24 macaque monkeys in 1998 that were inoculated with intravenous high-dose SIV and given tenofovir monotherapy at various times after exposure and continued for up to 28 days. Dr. Harrington also goes through this very well and has some beautiful slides on that. The link is there. There was greatest macaque protection when nPEP was given within 24 hours of exposure and for 28 days. There really hasn't been any significant human studies to confirm these cutoff points. So for now, we just base our clinical decisions on these 24 monkeys. The 72-hour limit should not be taken too seriously, though, because the macaque studies show that there is still some protection after 72 hours. And a person with a very high-risk exposure might get some benefit from any protection nPEP might give. In fact, the OPEP guidelines do not set 72 hours as a hard limit, but rather the most beneficial time to give nPEP after exposure is really undefined. Before nPEP is initiated, it is recommended to ensure that the person is not living with HIV already, and the HIV antigen antibody or antibody rapid test should be administered. Of course, screening for other STIs, including Hep B, Hep C, is important, as well as checking females for pregnancy. After the patient's initial presentation, they need to follow up with the provider to discuss tolerability, adherence, and even necessity, because sometimes the regimen may be discontinued if it is found that the exposure was lower risk than initially thought. And follow-up labs, of course, need to be drawn. So this is just a quick review of the exposure risk chart that's displayed in the guidelines. The highest likelihood of transmission is with blood transfusion, then receptive anal intercourse, followed by needle stick during injection drug use. And then an interesting point with the receptive or insertive oral intercourse is that there is still some risk with that, although the guidelines say that it's negligible, it is technically possible, and of course the risk increases if there is blood involved. So this is the nPEP 28-day regimen overview. All these regimens include 3 drugs. Adults and adolescents with a creatinine clearance greater than 60 are supposed to take tenofovir, emtricitabine, and raltegravir or dolutegravir. Now, for our hospital, I was trying to figure out which medication I should recommend that we put in our 3-day take-home packs. Most of us are familiar with the warning on dolutegravir use in women of childbearing age and the potential for contributing to neural tube defects. When this warning first came out, it was a result of the Botswana study, where the risk of neural tube defects associated with the use of dolutegravir were 0.9% in comparison with the 0.1% without the dolutegravir. A new update came out in December 2019 with a 0.3 risk instead of the 0.9%, and the perinatal guidelines from 2019 updated its recommendation for use as dolutegravir as preferred in all pregnant women regardless of gestational age, an alternative in women trying to conceive. And Dr. Hilary Liss had also covered this very nicely in one of the more recent ECHO presentations. People with high-risk exposure may not be trying to conceive, but it is an event that may result in pregnancy. This choice of recommending raltegravir or dolutegravir is tricky because there are benefits to using both, and using dolutegravir maybe not as great of a risk as we thought before. For our hospital, I'll probably just recommend to have both of those on hand. For completeness sake, I added regimens for people with creatinine clearance less than 59 and children, but we'll skip over those for the sake of time. Now let's do a little patient case here. Alice is our 24-year-old female that went to a party and had several high-risk sexual encounters. She presents 73 hours after exposure, and she mentions she does not use contraception because she wouldn't mind getting pregnant. She does not like taking medication. It is a Friday night. Of course it is. That's when everybody always shows up. Let's put that interactive question up, please. So what would you give her for her nPEP? Nothing, it's past 72 hours, TDF-FTC plus raltegravir, or TDF-FTC plus dolutegravir, and then phone a friend. Expert-to-expert consultation is sometimes needed. Go ahead and answer that now. All right, thanks everybody. It looks like everybody picked what I liked as well, although this was a trick question. I didn't give a solid answer here. I think that there, as usual, is more than one answer. And I also like the dolutegravir answer because this little lady, she does not like to take medication. We know that dolutegravir is less of a risk than what we previously thought, and we really want her to take it. People that don't take medication, it doesn't work. So she can, in fact, take the regimen once daily, which I think is the key here. Raltegravir was also a really good answer in that we have more data with regards to women of childbearing age, and the unfortunate part here is that she would have to take it twice daily and she might miss doses. Nothing, it's past 72 hours. This one is definitely an option too. I think her high-risk exposures really sent up a red flag for me in that there were several of them. She's super high risk, and 72-hour limit can be on a case-by-case basis. And then everybody knows what they're talking about, so it looks like no expert-to-expert consultation was needed, but I think that's always an answer too. All right, so this is Alice. I was thinking of Alice in Wonderland when I was putting this slide together, and it's about her and the timeline of events that might occur if she were to come in to get nPEP through the emergency department. So she and her provider decide on the dolutegravir option. She gets her first dose from the ED pharmacy in 3-day nPEP take-home pack. The 2 prescriptions are written for 30 days. This is all happening on Friday, and she takes her medication throughout the weekend, and then Monday comes along, and fortunately the PrEP coordinator calls Alice because the emergency department RN had Alice fill out a release of information and then left a message for the coordinator. The PrEP coordinator and Alice filled out a PAP application, which is the Patient Assistance Program, online and by phone. They did that together, and then Monday afternoon, hopefully that PAP application would be submitted and approved, and the funds would be sent to the pharmacy for filling. And unfortunately, a lot of pharmacies, they might not have it on their shelf, and so it'd be a next day fill. So on Tuesday, Alice is able to go in and get her medication. She would be out of medication by Tuesday, and so she's able to take her 5th dose because she was able to get to the pharmacy. Now, fortunately, this would be best case scenario. As we know, all these links don't always happen. So Alice's situation might have been close to best case scenario because she did follow up. However, many people do not contact the clinic after their first presentation. The patients who are less likely to follow up are those who have to pay for nPEP out of pocket, or if the exposure was from sexual assault. Adherence in taking the full PEP regimen is shown to be about 40 to 57%, which in my opinion is a little bit over half, which isn't ideal. They're most unlikely to finish were adolescent sexual assault victims and female. One intervention that might help would be to provide a 28-day prescription right up front instead of the 3-day starter pack. Because in one study, outcomes were slightly better in that there were fewer refusals, higher completion rates when the meds were given up front. This data is a bit controversial, though, in that it's possible that patients won't follow it up at all, and we may not know if they complete it. And also, the option to discontinue completely or change the medicine isn't quite there. Then we have to consider the mental health of the patient. Most of the people I have counseled in the emergency department are not in a good place to take information in. And one young girl that I met with after a sexual assault was completely catatonic and fortunately had a friend there with her that could relay the information to her later. So one of the barriers to nPEP that I've found is that providers are not consistently prescribing it. And if nPEP is prescribed, then the important parts of the process might be left out. When I work in the ED, I notice it's really tough to keep track of where the medication comes from, pharmacy stock versus our fancy drug machine, which is called InstaMed, and what they need to write prescriptions for. In a busy ED, it's really easy to not know that patients need the outpatient 30-day prescription. Also, staff in the ED are not aware of how expensive nPEP is because they're often not picking it up from the pharmacy. They don't see what happens on the other end of after they see the patient. And, it's easy to not have as high of priority for that. Really, I think all the ED staff, they do the best they can with what they're given. Inconsistencies here make it more important to keep the nPEP process updated. With HIV, we all know it's really difficult to keep our clinical documents up to date because the information changes so rapidly. Providers also have concern of drug side effects and viral resistance. Most ED providers do not encounter nPEP patients on a regular basis, and they may not know their nPEP guidelines to even follow, or they can't keep up with the updates. Providers have different ways of measuring risk, or they might assume that HIV is not a problem. These points are, in general, from my own experience in researching different facilities, as well as a study done in Georgia, which led to the nPEP toolkit, which is also listed on one of the last slides in the resources. So the Mountain West AETC, they actually worked really hard to do a survey in Oregon. This was last year, in fact, so it's very recent, where they interviewed ED and urgent care managers and charge nurses. Overall, there was a lack of written policies and procedures. Communication was not happening among team members, and especially there wasn't a lot of documentation on what to do with non-sexual assault patients. People were not familiar with nPEP community resources, and guidelines were not being used. The work that the AETC put in here revealed a significant need for training and education in the facilities. All right, so obtaining medication is one of the most significant barriers and is actually one of the things that I found that posed the biggest barrier. What many people want to know is who carries the nPEP packs or nPEP medications. It's my understanding that most patients show up to the ED after high-risk exposure and not so much the urgent cares or clinics. I'm really interested to know how many of you in the outpatient setting have had patients requesting post-exposure care. So maybe you can let me know in our conversation after. Most EDs will in fact carry the 3-day take-home packs, and the best practice is for the patient to get the first dose in the ED out of the hospital stock so they can take 3 days with them for a total of 4 doses. They will need this extra day to figure out how to get the rest of the regimen. Like our patient Alice, the best way to find a pharmacy that carries nPEP medication will be to find pharmacies contracted with a state ADAP or the AIDS Drug Assistance Program, because they will be filling a whole lot more prescriptions for patients in comparison to other retail pharmacies that may not fill very many. Let me be clear though, your patient will not be using an ADAP pharmacy on a regular basis because usually those are only for people who are diagnosed with HIV, but they might have the drug in stock and they won't have to wait another day to get it. So here's just a quick listing of the states that I notice are usually here at ECHO. Just a quick listing of the ADAP programs. There are a few links there. Some of them link directly to the pharmacy list that are contracted with the ADAP programs. Others, you have to maybe call one of the ADAP representatives. So luckily, the Oregon Board of Pharmacy just approved a really exciting law that allows pharmacists to prescribe nPEP, and they're also working on PrEP in Oregon. And I know Jeff LaRue, he's here today, he helped a lot on getting this approved to the Board of Pharmacy. Really excited about that. There will be some continuing education involved, nPEP and in trauma-informed care, and for the most part, it's geared toward retail pharmacists, but it'll be interesting to see how it all pans out when they figure out the kinks. So payment for nPEP is one of the most challenging for patients in that one regimen is about $4,000 for a 1-month supply. People might have private insurance, but for the most part, we have a lot of patients coming in without insurance at all. And for the people with private insurance, they might expect expensive cost sharing even. You have to consider all those big words: deductibles, copays, prior authorizations, formulary restrictions, all very scary and not amenable to people getting their medication. And then there are patient assistance programs for people without any insurance. There are manufacturer and non-manufacturer PAPs. And most patients, I think, will really need this assistance figuring out payment and filling out PAP applications. So here's just a quick list of the manufacturer patient assistance programs, and these can all be found on the toolkit as well. I just added it for completedness, and notice that there are limited hours. They're most of the day, but there are times when, in the middle of the night where representatives aren't available. Hence the Alice showing up on Monday to get further care to help get assistance with that filling out of the applications, because it can't always be done over the weekend. So really we want to set up our providers and the teams and the patients for success. And now, we need to be writing nPEP procedures and protocols. I think that if we are even able to help update, I think there's a great need for that. And each facility will provide different services around nPEP, and they're each going to have their own barriers and their own unique solutions also. Departmental procedures need to be updated or written so providers and teams are all on the same page. Written documentation of the nPEP process will help ensure guidelines are being used, create consistency in the nPEP process, and hopefully encourage ongoing connections with community resources. Ongoing education needs to happen regarding nPEP process availability and use of current guidelines. It is crucial that teams are able to provide a warm handoff to follow-up services, and that the services that they hand off to are relatively consistent and up to date with their information. And maybe finding a PEP or PrEP coordinator that is able to help reach out to the patient when they first get in the office. Even better is having an on-call person, but I would not consider this low-hanging fruit at this point, and that's probably a little bit more difficult to come by, although it could be a long-term goal. One solution that might be helpful for people not being able to pay is to keep the full 28-day regimen in the ER. nPEP prescriptions need to be written for 30 days to help ensure pharmacies won't reject them. And instructions can be taken or given to take only 28 days. And if the patient keeps taking it, it's not such a bad thing, because at least they're not being rejected from the pharmacy and they can take a few more doses. It's not such a big deal. Another thing that might help would be to provide the prescriptions that are supportive, such as Zofran, diphenhydramine, up front to help treat any possible side effects, such as nausea, insomnia, or headache. Lastly, I think each facility needs to find their PAP application champion. It might be a different type of person for each facility because communities are set up differently. It could be the PEP PrEP coordinator if you have one in your area. We're doing a lot of Zoom these days, so it's possible that maybe it could be done with distance. Not completely sure about that. But other people that might be an option would be social workers, the sexual assault RNs, medical assistants, and of course pharmacists. So in conclusion, I have to give you a little pep talk. So what would happen if each person on ECHO were to dig up nPEP processes in their community and either help facilities update or create processes? All right, so we want to avoid keeping Kaletra as our first choice, so it's just important that maybe we help update those processes. I do understand, though, in the current environment, some of us are just trying to survive, and it may be difficult, and even thinking about these issues is a good first step. We are a community here on HIV Echo, and we understand the medicine and also the patient population and challenges that come with nPEP. And coordinating nPEP might be one of the most complicated when it comes to keeping up to date and coordinating patient care. Is there a community organization that you might be able to partner with? What type of connections do you have with ED staff in your area? Maybe meet with a representative and figure out what the process looks like. This barrier of patients paying and getting their nPEP meds could really be the ultimate deal breaker, and I think we need to understand and use these patient assistance programs more. The problem is just figuring out who that point person is going to be that can help patients within each facility. So HIV providers and teams, which is all of us, will help and detect, remove barriers so patients may have improved access to nPEP. And there are many things here that I could not discuss because of time, so I'm interested to hear your thoughts and any barriers or solutions you may see within your facility or area. And then just some resources. We have the toolkit. We have the National HIV Curriculum, which has HIV Everything. Dr. Spock put that together. It's wonderful. And then, of course, the National Clinician Consultation Center PEP line. And that's all I have. Thank you.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.